Professor Ansels is from the Sinclair School of Nursing and the Department of Family and Community Medicine at the University of Missouri. She's also a research scientist at the Center for Clinical Management Research at the VA Annabelle Health System. She's also founding co-editor-in-chief in the journal Implementation Science Communications. She has completed over 40 funded research projects, in which many are focused on implementation research, and her work involves theory-based design of implementation interventions, including understanding how feedback reports affect provider behavior and how behavior change can impact on patients' outcomes, the roles of social networks in implementation interventions, and also effective implementation methods using electronic health records and digital interventions. So without further ado, may I involve Professor Ansels to share with us her experience. Professor Ansels, please.
Great, thank you very much. And Happy New Year, everyone.
Happy New Year.
And good evening. It's morning here. I'm in Michigan in the United States, but I'm very happy to be able to meet with you and talk about some of the opportunities that I think we now have with implementation research to be able to understand how to use our knowledge about people, organizations, and other things that impact what we do so that we can implement evidence-based practices. So just a quick overview of what I'll be talking about today. First of all, I have no relevant conflicts to disclose. What I'm going to talk about is how we can consider and think about context, the context in which you're doing the work of implementation. And then I will be talking about frameworks and different types of frameworks, how these are relevant to specific contexts. I'll use a very brief example as I do this, and then talk about how to think about selecting strategies for implementing evidence-based practices. So first of all, to talk about context, there's important features of context to consider. And when I say context, I mean the environment in which some kind of behavior needs to change. I'll talk more about that in the next slide. But if you think broadly about the environment in which you work, and here I'm assuming that we have a number of clinicians on the call who may be physicians, nurses, respiratory therapists, occupational therapists, physical therapists. If you think about the types of patients that you work with, they are part of the context because some people work with a single type of patient, patients with a particular disease. These are usually specialists. Other people work generally with all kinds of patients. That variation in and of itself matters quite a bit. Teamwork and how the team that you work with is configured is also an important part of context. Who are your colleagues that you work with as you deliver healthcare services? It's very unusual in today's world to have a completely solo practice. So teams are necessary, but sometimes the teams are very small, 1 or 2 people, and sometimes the teams are very large, 10, 15 people. If you think about a complex surgery, for example, the people going in and out of that OR suite may be, there might be 15, 20 people. The complexity of the teamwork, how many different things do people have to do? The rapidly changing evidence base, and this is a critical issue for most clinicians in most settings. The evidence that we use in today's practice, whether it is traditional Chinese medicine, whether it's what we call Western medicine, the evidence for what we do and why we do it is changing constantly. And so this is something that creates an element of uncertainty and ambiguity for clinicians. There's an ongoing need to interact with families and other providers. And then critically, data sources are changing all the time. I don't know what the situation is in Hong Kong or other parts of Asia with electronic health record implementation, but in the United States, because of a lot of investment in electronic health records, almost all settings now have electronic health records that provide medical care. And so those data sources matter, but those data sources don't talk to each other. So that again creates another feature of complexity within the context in which we do our work. And there are many other things. I'm just describing a few of the ones that we know to be important. So I'm going to just briefly talk a little bit about conceptual definitions, because this is an area within implementation research that is really quite difficult. And again, things are changing rapidly, so these definitions have changed a bit over time. I think it's very important to start with what is implementation. And I define implementation as a process of planned human behavior change under organizational constraints. I don't know that we need to spend a lot of time talking about that definition. The dictionary definition of implementation is simpler, but it simply says it's the process of putting something into place. And in this case, in health, when we talk about implementation of evidence-based practices, we're usually talking about changing existing practice and instead replacing it with something else. And that something else is an evidence-based practice or a bundle of evidence-based practices. And I think it's important to note that defining implementation then leads us to understand what the science of implementation is. It's the study of the planned human behavior change or changes under organizational constraints. And then I just want to put a final definition in that implementation practice, which is very, very similar to quality improvement practice, for those of you who are familiar with quality improvement, implementation practice is the process of supporting human behavior change under organizational constraints. So what these definitions lead to is a series of questions about whose behavior needs to change, what is the behavior that needs to change, how does the behavior need to change, what is the current practice, what is the new practice that needs to be implemented, and then what processes or workflows will need to change. And increasingly, we're understanding through implementation research that much of this is about workflow and the changes in how people do their work. So the first issue of whose behavior needs to change, the context is critical here because, as I mentioned, there are different kinds of team players and people involved in the work that people do who have different roles and different organizational characteristics. And understanding those is critical to understanding how this behavior change will play out within the organizational context. And then the workflow pieces really suggest that you need to think about who will the change affect? Who does it affect before somebody comes into the specific part of a care delivery system in which this behavior change is taking place? And what happens after somebody gets the new care? Do other things need to change upstream of the care or downstream of the care? So very quickly, I'm going to be using a typology of implementation frameworks, models, and theories that Dr. Per Nilsson in Sweden published in 2015. And one of the things that I find really important about the typology that he published is that it helps us to understand that even though we have many frameworks that have been developed throughout the last several decades of implementation research in health, they don't all have the same function. And the three that I'm going to focus on today to talk about the tools that you can use in improving practice and implementing evidence-based behavior in healthcare are these three down at the bottom: process models, determinant frameworks, and classic theories. And I'm going to use some very specific frameworks as I talk about each of these types of framework. Just very briefly, I'll just say that I'm not going to talk about classic theories or implementation theories, in part because the classic theories underpin pretty much everything I am talking about without being explicit about them. And implementation theories are still very much in development. So I'm going to focus on process models, determinant frameworks, and evaluation frameworks. So I'm going to discuss a specific process model. We have over 100 frameworks in implementation research, and it's not yet entirely clear what type of framework each of those is. but a large number of them are process models. And that's because many people have developed different ways of approaching doing implementation. And I would say that this is a case where I think there are many different process models that can be used. The one that has been recently published, it's published in 2019, and the citation is here, is called implementation mapping. And it actually comes from a much longer tradition called intervention mapping from health promotion research and practice. I'll be talking more about that in a minute. Determinant frameworks are used to assess context. So process models are used to guide the process and help you think about and plan what you're going to do as you do implementation. Determinant frameworks are used to assess context and understand the factors specific to the context in which you'll be working that will influence implementation success. And the specific determinant framework that I'm going to be using is called the Tailored Implementation for Chronic Diseases Checklist, which was published in 2013 and has the 7 domains that you see depicted in this little graphic. And then evaluation frameworks, there are not so many of these in the literature, but there are 2 that are quite dominant. One is the Ream Framework, which has been in the literature for over 30 years now. And there is a website, www.ream.org, that has a lot of very helpful information about this. And I'll be talking very briefly about that framework. Let me just say again, there are many other frameworks in each of these types. And my use of one framework is not to say that that's the only framework to use. These are the ones that I'm using. So they're the ones I'm most familiar with, but these are just examples. And I would encourage you to think about the opportunities and different frameworks that are available in each of these types. And then I'll just say very briefly, we're still developing frameworks. We're still developing frameworks in the 3 types I just talked about. And I think that it may be a need to think about a couple of additional types with some of the work that's been done. We probably need a type of framework or a category of frameworks that focuses on strategies, because we already have at least 3 different types of strategies and typologies. I'm sorry, not strategies, typologies and frameworks for strategies. In the United States, the one that's most often used these days is the Expert Recommendations for Implementing Change, or ERIC framework, that has a clustered map of what are 73 different strategies, implementation strategies that were collected, listed, and then conceptually mapped. And the Cochrane Effective Practice and Organization of Change framework of strategies, or typology of strategies, was developed many years ago and revised in 2016, I believe. And there are others that are out there. A paper published by Jennifer Lehman in 2007 actually provides yet another basis taxonomy for thinking about implementation strategies. And then the other type or category that I think we probably will be needing is one that focuses on adaptation or fidelity. And I've just listed a couple of those here. I'm not going to be talking about adaptation or fidelity today, but the strategies piece I will be talking about, and I'll be using the ERIC framework as a method of just illustrating how some of this works. Okay, so I'm going to now switch gears and move into talking about how to use these tools. And these are the tools that I mentioned in the title of this talk. I see these frameworks as the tools that have been developed through implementation research that we can and should be starting to use in practice. So if you think back to that definition slide I gave you, the implementation practice piece can use these tools and hopefully also help to make them better, make them more useful, make them expand them in certain ways, and a number of other things, which we can talk about in the discussion period. So using a process model, as I said earlier, is really to guide your planning and thinking about how to do implementation. And I would say within process models, there are different kinds as well. And so each of these large categories of types of frameworks can actually be broken down even more. And I would say that different process models are used differently in different parts of the implementation work. So what I have here is a little graphic that I created actually to sort of illustrate the implementation mapping process. In the paper itself that was published in Frontiers of Public Health in 2019, there is no graphic. So this is one that I created mostly to help understand how we use implementation mapping. So there are 5 steps. In the first step, you conduct assessments. You identify the participants by whether they are implementers or adopters. And the distinction there is not critical, except that implementers are the people whose behavior needs to change. Adopters are people who are often managers and supervisors within the context. So their behavior may or may not need to change, but they are responsible for the work and making the decision to make the change, which is an important distinction. You then assess the context. And here I would propose that you do that using the determinant framework that you selected, in this case, the Tailored Implementation for Chronic Diseases Checklist, or TICD. And then you begin the process of planning in step 2, in which you identify what your outcomes will be. What are you trying to get to? What is the desired future state from your current state after the behavior change has taken place? And by doing that, you can then start to map out what you need to do to get from your current state to your future state. You then select strategies, and this is where the Mrc strategies or any other group of strategies that you think about using come into play. And once you've selected the strategies, and I'll talk more in a few minutes about what that looks like. Once you've selected these strategies, you then can produce the materials that you need. You almost always need some training materials. You probably will need to map out protocols for some of the other components that you might be doing. For example, if you're doing a feedback intervention, you're going to specify how you're going to do that, and you'll begin to make sure that you can actually access data and produce a feedback report in order to do a feedback intervention. And then there's a lot of work embedded in this piece, and I would argue that this is the actual implementation step. And then you evaluate whether the implementation was successful. You may also be evaluating whether your end outcomes, such as, for example, have you actually changed blood pressure? If the point of the behavior change was, for example, to introduce a new medication to control blood pressure in people who have high blood pressure. If that's what you're looking for, you might evaluate, has blood pressure changed? But the real point here in the use of implementation evaluation frameworks is to understand whether the implementation was successful or not, so that if it was not fully successful or not sufficiently successful, you can go back and change the pieces that you need to change. I'm not going to actually pause for questions or comments during, excuse me, during the talk, because it sounds like it would be best to leave those to the end. So I'm going to move on. So I've mentioned that we have many, many frameworks, over 100, that have been developed through implementation research. So the question is, what frameworks are relevant to your work? And again, think about this in the context of what I was talking about earlier, that we had the frameworks have different functions. So when you think about all of these frameworks, for example, if you're working in a critical care or intensive care unit and doing behavior change, which is an example I would use in a couple of minutes, none of those frameworks are specific to critical care. There are actually a few frameworks that are beginning to emerge around critical care, but none are yet fully developed. But I would argue that it's not clear that the frameworks have to be specific to the setting and context that you're working in. Part of the point of using frameworks is to think adaptively about how to use them within your context. And even if you use them in primary care, which is where most of these frameworks come from ultimately at this point for a variety of historical reasons, even if you use them in primary care, you will still need to think about primary care in your context, in your setting. And I will just say, I think we all know that primary care is not the same in all places in the world. Primary care, even within the US, which is a single country, varies from one state to another, and it varies from different organizational settings to another. So thinking about how the framework will work within your context is the first step that's really critical as you decide what framework to use. You shouldn't expect that any framework is exhaustive. You shouldn't think that a framework will cover everything that you need. It will cover many of the things that have been shown to affect implementation and the success of implementation. But you may have to add elements. And I will just say that frameworks are not set in stone. At a recent national conference in this country, Laura Damschroeder, who is lead developer for what's called the Consolidated Framework for Implementation Research, just described and kind of unveiled the 2.0 version of that framework. And I think that's an example, a good example of recognizing the need to adapt and change and modify frameworks as time goes on and as things evolve. All three types are relevant. So as you think about selecting frameworks, you might want to think about specifically selecting a process model, selecting a determinant framework, and selecting an evaluation framework. And you may need additional types. And I would argue that probably you need to think about selecting a strategy framework in addition to the other frameworks. So there are published studies, and I've cited one here that Sarah Birkin led, published in 2018, that goes through steps and offers some tools that are available on the web for selecting a framework. There's also this website that Borsika Rabin and her colleagues have developed and continue to maintain, which actually offers you the whole menu of frameworks and allows you to put in specific criteria that you're looking for, and they will try to match, the website will try to match the frameworks that are available to your criteria. And some of the frameworks have extensive guidance available on the web. The Consolidated Framework for Implementation Research, or CFR, has a website that's very useful called cfrguide.org. And I've already mentioned the ream.org website. I would encourage you, if you're using these tools and beginning to get into this literature, to use these websites and the papers that I'm citing here as references and ways to think about doing this work. But you want to have your criteria. None of these tools will help you unless you've thought through what it is you're trying to do and you understand some elements about the context in which you're working and what it is, what the behavior changes that you're trying to promote. So the other thing to think about that's specific to the frameworks is, when were they developed? How recently were they developed? And I would argue that this is particularly important in determinant frameworks, where consolidation through systematic review of the literature is a very important feature. And the most recent consolidated framework still, although there may be others that are kind of in process at this point, is the one that I've been talking about, the Tailored Implementation for Chronic Diseases Checklist, published in 2013. So as you can see, it's almost 10 years old now. And so hopefully there will be a new reconsolidation of the literature. But you also need it to be fit for the purpose that you intend. And that means to some extent fit to context, but also fit to the kind of implementation that you're doing and its complexity. And then finally, you need it to be accessible. It needs to be something that you can actually use without too much effort, just the background pieces. So I'm just going to say about that piece, the frameworks themselves are lists of constructs or concepts. So they're simple words, and there are very, very brief definitions. If you go to this, I'm sorry, oops, that was not intended. If you go to the cfrguide.org, let me see if I can, there we go. If you go to the cfrguide.org, for example, you will see that there are brief definitions given for each of the constructs, the 39 constructs that are in that framework. And that's very helpful, but that's very brief. And what you need to understand is underlying all of those definitions are the theories that give rise to why this construct exists, why leadership is important, for example. And there is a very large literature for many of those constructs. So I'm not suggesting you have to learn all of that literature, but if you're working particularly with a very broad construct like leadership, doing some reading in the area of leadership as it relates to implementation is important and something that's important to think through. Okay, so now I'm moving into more of the details of how you actually use frameworks to design and develop implementation interventions. And this is really the work that I focus on. So in this, what I'm proposing is that you've already gone through the stage in the process of doing your contextual assessment, and now you're in what's step 2 in the implementation mapping process, where you're beginning to think about the outcomes that you're trying to achieve and all of the stakeholders that are involved, and identifying who's an implementer, in other words, whose behavior needs to change, and who's an adopter, who is there and important to the work, but not necessarily whose behavior needs to change. And I would suggest to you that when you get to this point, although in step 1, you should be using determinant frameworks, but now the determinants that you've assessed in step 1 become important to actually beginning to design how you will do the implementation. That's because the determinants are these constructs, these brief descriptions that provide very succinct and short descriptions of the important factors that influence success or failure of implementation in the context in which you're going to work. So having used a determinant framework to do the assessment, you now use the information that you've gathered from that to be able to think about how are you going to overcome a barrier, a negative determinant, or how are you going to use a positive determinant or facilitator to help you do your work. And this is what I call implementation interventions. There are different terms used for this concept, but in general, in implementation research and practice, it's understood that the point of doing implementation practice is to support behavior change. And to do that, you need to actually do the planning work that allows you to help the behavior change happen. So the implementation interventions need to include strategies and behavior change techniques to overcome barriers. And I'm going to talk about this little graphic more in detail in a couple of minutes. But the point of using this approach, which is called implementation research logic models, is because you need to think that the way to think about how choosing a strategy depends on why the barrier or facilitator exists in the first place. So what is the mechanism, the theoretical mechanism that makes that barrier exist? And what theoretically would be a strategy that works to overcome that barrier? So what we're looking for are causal mechanisms for determinants and mechanisms of action for the strategies. And that sounds as though this is a lot of theoretical thinking, which many people think of as not relevant to practice. Many people think of theory as being something that is only done in research and only done by scientists or theoreticians. But in fact, we use theory all the time in the work that we do. And I would urge you to think about theory, not in terms of big theories like the theory of planned behavior or the theory of reasoned action, which underlie many of the concepts and constructs that are in the determinants frameworks, but to think about in a simpler way, why are people behaving like this? Why are they saying, this isn't possible to make this change? when you start the process of changing behavior and implementing a new practice. So I'm going to do a very quick worked example and a partial example, but this is about implementing lung protective ventilation for adult patients who are mechanically ventilated to treat acute respiratory failure. It's very relevant in the COVID era, but it's also a very high-end technical evidence-based practice for people who are acutely ill, typically cared for in critical care settings. But those critical care settings might be an emergency department, might be an intensive care unit, or in the case of COVID, where we've had surges that have required taking beds and turning them into respiratory intensive care units, important things to think about for patients who need mechanical ventilation. But I want to stress that even though this is a high-end, highly acute example that I'm using, the principles are the same for implementation as if I were talking about using a new evidence-based practice, like a new drug that's been shown to be effective for high blood pressure in primary care. So the practical steps following implementation mapping. The first is to conduct the assessment and identify adopters and implementers. So that's a matter of understanding the people in the environment in which you're working. And there are some emerging processes and approaches to stakeholder identification and analysis. But for the most part, this is a fairly straightforward piece that most people just sort of do on their own. You need to think about whose behavior needs to change, because anyone whose behavior needs to change is a stakeholder. So if I weren't using lung protective ventilation, but if I were using instead infection control in a hospital, a key group is the housekeeping staff, the people who do the cleaning of the rooms, who are often ignored when we do implementation, but who are often critical. In lung protective ventilation, housekeeping staff don't really have a role to play, but respiratory therapists do. Nurses might, physicians certainly do, and patient families may have a role to play as well, because they may have very strong feelings about use of mechanical ventilation, for example. So that piece of identifying stakeholders is critical. And then using the TICD as a determinant framework, this little graphic in this picture here, we construct an interview guide, and I've just shown the first page of that. That's actually built on the TICD. So the domains are over here. As I said, there are 7 domains in the TICD, these little colored boxes, and we have questions that address the constructs within each domain that ask important questions like, are you familiar with lung protective ventilation and what the recommendation is, and what's needed to actually do lung protective ventilation? That's the kind of question that we ask. So we do these interviews, and then we analyze the data. We use template analysis, which is an approach that, instead of just open coding, begins with a code book that we base on the TICD. That's what we use to construct the interviews, the guide, and to do the interviews. And now we actually code into it. But we also remain open to the idea. As I said, frameworks are not set in stone. There may be some things that are missing. And in our work about lung protective ventilation and other evidence-based practices related to mechanical ventilation, we have found that there are things that are not in the TICD that are clearly important in intensive care and critical care settings. Many of them are around concepts of teamwork, which are in the TICD, but they're more detailed concepts of teamwork because teams are extensive within intensive care and critical care, and they do things that are different from in primary care. And so that makes it important for us to add new constructs potentially that we would be using in our coding of the interviews. So once you code the data, you then say, okay, now we know which constructs appear to be important, appear to have relevance to implementing this evidence-based practice in these settings. But you could have 15 or 20 of them. That's not unusual at all. As I've said, TICD has 7 domains, and it has at least 57 constructs within those domains. The CFR has 5 domains with 39 constructs within them. So if you have 15 or 20 constructs, that's probably more than you really have the resources or necessity of designing into your implementation intervention. So typically, this is a point where we consult again with stakeholders. We might use a rating approach that's in the paper that I cite here, but we're aiming for a parsimonious, smaller set of important determinants. And I would say somewhere between 5 and 8. Sometimes you go to 10, but once you get above 10, you're starting to design an implementation intervention that will be unwieldy and very complex. And the implementation intervention sometimes is even more complex than the clinical intervention that you're focusing on. And I would argue that that's not a good use of resources. So now I'm going to talk about the second step, which I alluded to a couple of slides ago, where we use the implementation research logic model to define the outcomes. So if you look, this may be hard to see because of the screen, but hopefully you will all get the slides. You can look at it in more detail. And I've cited the paper previously. You actually start here by saying what your outcomes are. What are the implementation outcomes you want to achieve? What are the service outcomes? What are the clinical or patient outcomes that you want to achieve? And these all come actually from a paper by Enola Proctor that's cited in the 2020 paper describing implementation research logic models. In their approach, and we have modified this graphic a little, which I'll show you in the next slide, but in their approach, you list then the determinants in each of the categories or domains. These are now the prioritized determinants, the ones that have been found and felt by you and the stakeholders to be the most important. You list these under each domain, and then you start to look at the mechanisms of action, of strategies, to see what might be able to overcome a barrier or use a facilitator effectively to promote the behavior change that you're trying to promote. And then I'll just briefly say, there's just this box here allows you to describe the clinical intervention. So down here, we would put lung protective ventilation for mechanically ventilated patients. So this is an example of the implementation research logic model that we developed based on lung protective ventilation and the assessment that we did. And here we're using the TICD domains. So one of these is individual health professional factors. And I'm not going to go through the whole thing in the interest of time, but I'm going to talk in some detail about 2 of these. So under these, in the prioritization process, three constructs came out as important and something to be dealt with. And all 3 are barriers. So here, the domain knowledge was one of the constructs that was identified. And lack of knowledge about the topic or domain is the mechanism. So people just don't know everything that they need to know about lung protective ventilation. And in particular, they often don't understand the critical nature of knowing the patient's height and weight and not estimating the height, which is often a big problem. So here, because the issue is a lack of knowledge, the mechanism that you're trying the strategy that you want to use and the mechanism underlying that strategy is to facilitate learning. You want people to be able to understand and know what lung protective ventilation is. So that implies education. But I will just say right here that we also found in our assessments that even though there was some knowledge lacking, overall, people knew enough about lung protective ventilation that they knew what it was. And many people understood how to do it, but not necessarily the final step of how to do it in practice. So the education isn't a webinar like this, where we go through all the steps of lung protective ventilation. The education that may be needed is much more targeted to understanding the specific knowledge that's missing and helping people address that gap. Knowledge of own practice is frequently found to be a barrier. And what that means is people don't know their own practice. They know the recommendation, but they don't know how well they follow that recommendation. And this has to do with critical gaps in data and data access for providers that are quite global in context. Very few healthcare providers know and understand what their practice is. We don't get the data that would help us know that. And so the mechanism there is a lack of awareness, or they may have a bias about recall, or lack of knowledge about how other people are doing, comparators. So the mechanisms of this strategy then, of action of the strategy that you're looking for is, how do I improve awareness? How do I give people an unbiased presentation, not based on what they can recall or what they think they know, and offer relevant comparisons? And the strategy here is an audit with feedback intervention or strategy that allows people to be aware of their own practice and to improve, to understand what their peers are doing and strive to get their own practice aligned with their peers, so that they are actually practicing, first of all, more with the evidence, and also more with the people that they're practicing with. I'm just going to very quickly mention that capacity for organizational change is often a domain in which many constructs are salient and important. And this is where the organizational constraints part of the definition that I gave earlier becomes really important. These things are all things that a health professional can do by themselves, but they can't access the data themselves easily or effectively, typically. The organization has to participate and support an audit with feedback intervention. And so that gives you a sense of context right there. If, for example, you're practicing where there are no electronic health records, amassing the data required to do a feedback intervention is hugely time-consuming and difficult. I've worked with some colleagues in Australia where electronic health records are only just beginning to penetrate. And so they had to do hand audits of data in order to get the data to do a feedback intervention. That makes it very expensive, and it makes it hard to do. These are organizational issues that very much affect whether a strategy is feasible or not, or what it's going to take to get that strategy done. So I'm going to very briefly talk through the last 3 steps in implementation mapping. So in step 3, you select strategies. And I've just gone through in the last slide, the logic that's required for making the decisions about what strategies to use, given what you've assessed as salient and important barriers or facilitators, negative or positive determinants. So it takes more, though, than just saying, okay, we have 3 strategies we're going to use here. And I'll just quickly go back to the last slide to say, we might say we have to do some education, we need to do a feedback intervention, and we might need to work with leadership to get them to mandate the change so that it's a high priority and not just something else people have to do. Those 3 things then have to be packaged, and we need to think about sequencing them. We have to think about designing each of them to actually address specific elements of context. And this is where other frameworks come into play. There's the behavior change technique taxonomy, which catalogs a set of evidence-based behavior change techniques that are at the smaller micro level, focusing on individuals, that can be used to actually design in elements to make, for example, a feedback report much more successful. So that is what I'm calling micro design. You have to go into the details of the strategy. And this is the step 3 going into step 4. As you do that, and as you prepare your protocols and manuals, you need to move this forward. You need to be parsimonious. You want to think about disentangling the effects if you're doing this as research, you need to think about, can I actually measure the effect of one strategy versus another, given that we're doing multiple strategies? And if we're doing research, we need to think about what we need to learn to advance science. So I'm not going to dwell on that because my focus in this talk is more on using these in practice, in practical ways, rather than doing research. But in the question and answer session, we can talk more about the research aspects. Producing the implementation protocols and manuals in step 4, thinking through what do I need to be able to get this implementation intervention together. In today's world, you might do videos rather than putting together a manual because people can watch a 5-minute video and assimilate the information more easily often than they can read a dense and complicated manual. But it will depend on the adopters and implementers that you've identified in step 1. The adopters will make decisions for the organization about what's feasible and what can be done. The implementers are the people whose behavior needs to change, and you need to think about what they need in order to do this work. And then you need to think about who's doing the design work here of designing the implementation intervention, but who they're going to hand it off to, who will actually be enacting change. It's often information technology people, IT people, who are involved in many of the things that we're doing in today's world. So I just want to say that hopefully through this, you've gotten the point that stakeholders are critical. It's really important to identify and analyze them early, engage them throughout, and understand who does what when during the process. Then finally, and I won't spend a lot of time on this, evaluating the success of the implementation that you've done using one of the frameworks that's available. The two that are most often used are Ream, or what's increasingly being called the Implementation Outcomes Framework, or IOF, or the Proctor Framework for Enola Proctor, who was the lead author on the paper in which these were described. And these are listed here. As you think about it, when you review the slides, you'll see that these are the 3 categories of outcomes that are in the implementation research logic model. But there's also a choice here, deciding which framework to use. And I'll just say I'm in the middle of writing proposals for implementation studies with colleagues at the moment. And we have to stop and think which of these 2 frameworks we're going to use, because even though there's a lot of overlap between them, there are also some key differences. So to summarize, despite the proliferation of frameworks, there are principles that we can use that help make sense of them and help us use them. And understanding the function of the framework and thinking about how you will use it and its function in the work you're doing is critical. Understanding when one type of framework is more useful than another. And I would argue for actual design of implementation interventions, as I've shown you in the example, determinant frameworks are the most useful. They are the pieces that will give you the information you need to actually choose implementation strategies. And I hope I've shown you it's not a perfect science, but there are principles and theoretical components that you can use to go from the barriers and facilitators that you assess through the determinant frameworks to selection of strategies. And then among the frameworks, there are some criteria and some selection methods to use. And mapping the mechanism of change to the mechanism of the causal mechanism for the determinant is probably a critically important piece. So I am going to stop sharing at this point, and maybe now is a good time, Dr. Chung, to take some questions, and then we can move on to a shorter presentation about publishing in implementation science journals.
Thank you very much. Thank you very much, Professor Sales, for your excellent talk. So is there any questions from the floor? You can type your questions in the Q&A box and I'll read it out on your behalf. So at the moment, we don't have a question now. I do have a burning questions to ask. So you have introduced several frameworks that you may use in implementation research, so including determinants frameworks and also process framework. And you are saying that determinants framework may be most important because these are the things for you to diagnose the implementation problem. And so there are many different determinant frameworks, of course. So is that the case that actually we can still use the logic model to actually map out the whole process, despite the fact that we use different types of models?
Yes, exactly. The way that you do that is actually fairly straightforward. You simply replace the boxes for the domains for whatever framework you are using for the determinant framework. But I'll also say that I not infrequently, when I review applications for implementation research, I see a statement like, we are using the Ream model as our framework globally for the entire study. And the Ream framework or the Prism framework, which is actually an updated version of Ream. Prism has a few determinants kind of embedded within it, but it's only a few. And they're actually more at the level of a domain. So I would argue that making that decision, making that choice to use a determinant, not to use a specific determinant framework, but to use a framework that can be a process model. Certainly Ream can be used for process. It is excellent for evaluation. But for that determinant piece that's kind of in the middle of the process, I would argue that it's not very useful because it leaves you to think about and come up with all the ideas for and questions for what are these determinants. Whereas the CFR, the TICD, and the theoretical domains framework, which I didn't talk about very much, are much more descriptive and have a lot more information in them.
So with regards to the design of the specific implementation interventions, you mentioned that it is important to actually find out what may be the possible mechanism that will actually contribute to their eventual effectiveness. So how do you actually find out those mechanisms?
That is an excellent question. And the answer to that lies in, that really comes from you. And that's why understanding the theories that underlie the constructs in a determinant framework, for example, is very important, because you need to be the one to say, okay, so we see that leadership is important here, for example, and it almost always is, or knowledge is important. But you then need to think about the specific elements of leadership that matter, because there's a huge literature on leadership in the organizational studies literature, in psychology, in a number of other places. And the burden, unfortunately, is on us as implementers to understand which of those elements matter and how we can use a design strategy to affect leaders. So it might be persuasiveness, it might be showing them the data so that they think about and make a decision. That's where, again, there may be strategies needed to actually get that piece moving, for example. Yeah.
So actually, I'm doing some kind of a survey on all these frameworks and also intervention design methodologies. I do see some sort of couplings of frameworks and intervention strategy development tools. For example, theoretical domain frameworks coupled with the behavioral change wheel, or CFIR coupled with the Mrc framework. So for beginners who are not very familiar with the whole range of tools that we may use, do you actually recommend us to use kind of linked models? So it is easier for us to actually choose and select and design, from diagnosis to intervention, the whole process of implementation project? Or you think that you should be more flexible about what sort of things that you may do, or you can choose optional questions or optional strategy that is outside of the established models of work in these
that again, that's a great question. And I think pragmatically, the tools that are being developed, and as you say, the behavior change wheel itself is a tool to try to help people use the theoretical domains framework, which is actually the largest and most complex of the three consolidated determinant frameworks. I think that, yes, if you decide that that's the approach you want, and I will just say that approach is very much about individual factors. It has some organizational factors associated with it, but that's a small piece of what they do. But using tools like that, or the CFR, Eric, if you go to the cfrguide.org website, there is actually a tool that you can use to map directly from a construct to strategies. But you will still need to do the prioritization, and you'll still need to do the stakeholder discussions to understand how to use them. But I would say just a little bit deeper than that, one of the reasons why we need to reconsolidate periodically and come up with new determinant frameworks that are somewhat broader is because the frameworks do age, and none of the current determinant frameworks that we have address information technology in any serious way. And yet, increasingly, the work we do is based on electronic health records and information technology, and we're using digital interventions increasingly. But none of these frameworks really incorporate that. So I would strongly suggest that this is why we need to continue to progress the field. And I think that that can come from practice. As I said, whatever determinant frameworks you use, you should always think about additional things that are not captured in the framework. So long answer, but this is why we have to keep doing research as well as practice in this area.
Thank you very much. So we have several questions from the audience. So Professor Sells, can you actually read it on the screen?
Sure.
If you click on the Q&A tab. Yeah, so the first question is from Patty Lam. So she mentioned that, do you actually agree that the concept of implementation science strongly related to project or business management theories, or from the business school side?
That's a terrific question. And my answer to that is yes, but the business school side and the organizational studies side, which is usually what business schools deal in the most, sometimes undervalues the importance of the individual. And especially when it's business school information that's been developed outside of healthcare, it often doesn't recognize the critical nature of roles and professional status in healthcare, which makes a huge difference in terms of whether or not people will be able to make the behavior change. Because if you're asking somebody who's a nurse to do something that's outside of their scope of practice, for example, that's not going to go anywhere. So, but I agree with you completely that I think we're not using the business literature sufficiently in implementation science much of the time because we are not focusing sufficiently at the organizational level.
Okay, so and then we have a comment from Professor Ikeyo, actually addressing the issue about flexibility in understanding the context and also in the design of the intervention. So he mentioned that in some determinants and for different intervention, in different contexts, they may have different mechanism, and probably we have to establish the strategy in accordance to the context because all these things are variable. So Professor Sells, do you agree with the statement, or do you have any comments or additions?
I absolutely agree. And I think that this is really, you're pointing out a critical piece. This is why, even though I think we should be publishing and populating the mechanisms, and I think we need to be doing much more work on that in the research world, in reality, because the context will vary, you actually need to describe the mechanism in your context. And as you point out, there may be different mechanisms from one context to another. So if you're working in a long-term care setting, the issue of knowledge and who has knowledge is going to be quite different than in an acute care setting or in a community setting. And I think that it's really incumbent on people to understand and figure out what those contexts are and decide what are the theoretical elements that matter.
So just a follow-up question. So let's say if I want to write an implementation research project, which is specific to circumstances in Hong Kong or in China. So these things can be quite specific to our own healthcare system. So when we write papers, how we are going to ensure that the findings are having some implications to other health systems? Because let's say I want to publish an implementation science, they're looking for something really generalizable and innovative. So, but still our research is quite confined to one health system or at most two. So what would be your recommendation on that, Professor Sales?
So let me just say that's true everywhere. And, you know, this is getting a little bit into the publication piece, but I'll just say that I think it's 80% of what we publish in implementation science. Not quite so true for implementation science communications, but for implementation science, 80% of what we publish comes from the United States. And the United States has a healthcare system that is quite different from many, I would even argue most countries in the world. And I think we've not done a great job yet of saying to people, you know, you need to give us some information about your health system, including in the US, that could be published as an additional file. It might not be in the main text, but someone can read it and say, oh, okay. So let's just say in Hong Kong, you might be having traditional Chinese practitioners working side by side with people using Western medicine, which I know is the case. So if that's part of the context, then part of that might be an interaction between providers who come from different, you know, understandings and knowledge, different evidence bases, who are interacting with each other and maybe taking care of the same patient. So how does that context matter? How does the context of how healthcare is paid for matter, which matters a huge amount because it affects whether a patient even can get care for their condition and whether it's accessible to them. So those are two important contextual factors that I think, you know, so what I would say is, I think as journals, we're interested in publishing everything, but the more people can say briefly about what their context is in that sense, the more it will be helpful.
Thank you. So we have two more questions. So the first one comes from Chris Chen. So he wants to know a bit more about the analysis of determinants and process from both quantitative and qualitative perspective. From my feeling, it seems that the field is quite qualitative dominant at the moment.
Yes. So there are survey instruments that are being developed to use for determinant assessments. The problem is, as I've noted a couple of times in the talk, the list of constructs is very, very large. And so the surveys we have are either very blunt and they work at the domain level, which is a much smaller number. So 7, 5, 14, as opposed to 57, 39, 93. A survey that asks 93 questions is not feasible. So what I would argue is that a feasible approach, because I agree that doing this purely qualitatively can be problematic in a lot of ways, is to start with qualitative interviews. And once you've narrowed down the domains and the constructs to, you know, a smaller number, then you can you actually have to then develop a brief survey instrument. And I think one of the things we should be thinking about is guidance for how to think about developing those survey questions. And I think that might be a more useful approach than to publish survey instruments and say, this is the way to ask this question. Because again, it's contextual. You know, if I ask a question about, to a nurse, how do you do this? That depends on what that nurse is allowed to do in that context. It varies widely globally, and even within countries, like in the US, it varies from state to state. So those things make a big difference. But I would just say that analyzing, I spoke very briefly about the analysis of the qualitative data. Just we use, as rigorous methods as we can with the analysis qualitatively. The quantitative analysis is usually descriptive. But I think increasingly depending on other data sources, you might be able to apply it to sources that would give you other pieces that might allow you to do deeper analysis.
Thank you. So we have a last question. It is about the way or the algorithm to choose different frameworks or theory for implementation research. I think you have briefly mentioned that two sources before in the talk. Yeah.
So there's the paper by Sarah Birkin, which uses a tool called TCAST that I think is a reasonable way to go about this. And then there's the disseminationimplementation.org website that allows you to input your criteria and it will offer you some frameworks. The one thing I will say though about those two approaches, which I think are reasonable, is that they don't actually use the typology. So they don't divide the frameworks into the process models and the determinant models and the evaluation frameworks. So what they might give you is, a framework like Ream, but it may still not be adequate for the determinant step of the work that you're doing. My own feeling is you probably don't need one framework, you probably need 3 frameworks to do this work well. And that seems overwhelming to people. But once you actually think about the fact that they are doing different things and the process model is guiding what you do, the first step might be to choose the process model and to think about that initially.
So you're saying that we have to use process model, determinant frameworks, and also evaluation framework simultaneously to make it comprehensive. And we can bring it all together using the logic model.
And the process model, because where you use the other 2 frameworks is guided by the process model. So it's not exactly simultaneously, it's within the same project, but in fact, it will be at different points in the project.
Okay, so also one additional question, should we use theory? Many recent reviews show no difference between using theory and non-theoretical approach for implementation research. What is your take?
So I'll just say that my position personally is, and this is a debate that's been going on for years, is that if you don't use theory, then what are you using? You have to have some principles on which you operate, right? You have to make decisions about what to do. And if you're not using theory to make those decisions, what are you using? And the answer usually is our intuition, our knowledge as a research team or as an implementation team. We're going to use our embedded knowledge. Well, I'm going to propose to you that that's theory. It's just not grand theory. And there's a paper led by Frank Davidoff that is called Demystifying Theory that I think outlines these issues very well. And they basically say in that we are always using theory. It's not a question of whether or not to use theory. It's a question of how we describe that theory. And that, I think, is a critical piece to understand. You always have some theoretical reason for making a decision. And how explicit you make that theory is the important question. And whether or not you survey theory or just go with your own intuition, I would argue that the one thing we have learned emphatically and decisively from implementation research over the last 3 decades is that when we just base it on our own thoughts about what we should do, then we are limiting ourselves to a much narrower set. And I see your follow-up, which is that theoretical guides limit choices. You're right. And the choice they limit is in the strategies. And that is, I agree with you. We actually need to be more creative than those strategies are right now. Those strategies were actually collected 10 years ago. And the world has changed a lot in the last decade. The issue, though, is be explicit when you're creating new strategies about what is the theoretical perspective that you're coming from. Why are you choosing these strategies? What do you think the mechanism of action is? And I'll say, absolutely, we do need to be more creative and we need to explain these, but without some theoretical base that may come from literature, that may come from our own knowledge and experience, without explicitly stating that, it's very difficult for other people to use that information in the future.
So if there's no further question, maybe we can move on to the publication part, right?
Great. Yep.
Okay.
Great. So let me go ahead.
Yeah, I think there's another question from Cherry Yuan in the chat box. Would you like to answer that as well?
Sure.
Yeah.
Okay.
It is about a medical research council's framework.
Okay. Yeah. So this is about the MRC framework. So let me just say there are two MRC frameworks. There's one that was published in 2000 and one that was published in, oh, let's see, when was that? 2006 or 7. And the second one, the one published later, is much more detailed and much more complex. I actually have to say I like the one published in 2000 because it had, it was simpler, it was easier to follow. Both of these, however, are process models. So that's the first thing to understand, that they guide the process and decision-making and help you understand where and when you need to make decisions. And I think that I would say, yes, you might want to use a determinant framework in addition, because the MRC guidance, none of it actually is really about the determinants. It's about, the steps to take. And so I would recommend using one of the determinant frameworks as well.
Okay.
Yep. Do you have anything to add, Vincent?
No. Maybe we can move on to the publication discussion.
Yeah. Yeah.
Yes. Okay. Over to you, Anne.
Great. Okay. So I'm assuming you can see my screen, and I'll just put these into slide mode. Okay, so I'm going to talk briefly about different journals in the field, but I'll also describe some of the issues that we face as we publish, or as authors, we submit papers. So implementation science has been, was first published in 2005, 2006. As you see here, the scope, the purpose is to publish research and methods to promote the uptake of evidence-based healthcare interventions, practices, or policies, or the de-implementation of those demonstrated to be of low or no clinical benefit. So the access is open, but the point here is that scope isn't open. And implementation science is now getting more than 800 submissions a year. It has a very strong impact factor at this point, which I think is mentioned on the next slide. But so we get all kinds of submissions to implementation science. Many of them have nothing to do with implementation. And some of those that have something to do with implementation may not be research and methods. They might be descriptions of an implementation study that was done without much analysis, but just basically descriptive. So implementation science focuses on publishing studies that have a high degree of rigor and definitely publishes both quantitative and qualitative designs, mixed methods designs. Design is not the issue, the content is the issue. So in implementation science, the priority is to review and publish studies that make substantial contributions to the field. Implementation science is also, as an open access, excuse me, web-based publication. It's pretty quick, 20 days to the first decision, which for those that are reviewed is usually a revise and resubmit decision for all manuscripts, and 71 days, so roughly 3 to 4 months for the reviewed manuscripts. As I said, they get over 800 submissions, and only a small proportion of those actually get reviewed. The remainder mostly get transferred, largely because they're not in scope, and some because they make what is considered a marginal contribution because they're primarily descriptive. It currently has a pretty high impact factor, 2-year impact factor of 7.3 and 5-year impact factor of 8.7. So all of these are important metrics. They're especially important for people who are in academic settings and who are facing issues of promotion, contract renewal, and depending on your context, tenure decisions. And it's highly accessed, lots of altmetric mentions. So implementation science by many people is regarded as kind of the flagship journal for the field of implementation research. Implementation Science Communications was launched in 2019, and it's officially a companion journal to Implementation Science. I'm one of the co-editors-in-chief, and Professor Xu in Guangzhou is the other co-editor-in-chief. It's a broader scope. We're still very focused on implementation, however. So we do get submissions that are outside of our scope, and those we try to help support finding a better home for them. We take a wider range of types of study reports. For example, we'll publish case studies. We'll also publish reports from single sites, which implementation science by and large does not anymore. We do have a direct transfer route that papers can be transferred directly from implementation science to implementation science communications. We do still, though, focus on rigor and innovation. And so when papers simply repeat what's in the literature without new additional information, and often without a great deal of rigor in the methods, we often still will not accept them. We have open peer review, actually in both journals, although that will be changing sometime in the near future to what's called transparent peer review, which I can talk about more if people are interested. And the website is here. So we have a rapid turnaround time. We do our initial assessment, which is at the editor-in-chief level, generally within a week. We do accept a broader range of types of studies, and we often will accept the descriptive studies that are no longer being accepted in implementation science. And one type of descriptive study in particular we get a lot, and we are publishing, which is assessment of barriers and facilitators without the next step of actually doing implementation and reporting on the results of the implementation. We have, excuse me, we have a set of, excuse me, active and engaged editors for both journals, I should say. But we do ask for both journals to please review the scope before you submit. And we have just in the last 2 months published an updated editorial that describes common reasons for rejection from both journals, and also describes in more detail some of the differences between the journals. So I would encourage you to take a look at that editorial. But I think it's important to say that there are other journals in the field of implementation science and implementation research. These are to some extent newer. Implementation Research and Practice is a fairly new journal. The website is here. It's published by SAGE. And it is the journal of the Society for Implementation Research Collaboration, or SIRC, which is a largely US-based society, although its membership is open globally. Focuses largely on implementation of evidence-based psychosocial interventions, which is true of SIRC as well. So its main focus is on behavioral and mental health services, but they do publish a wider range of implementation research as well. And I think the important note here is that they focus on both implementation research and practice. Implementation science and implementation science communications typically do not publish papers that are purely about implementation practice without a methodological research component to it. So I think this is an important thing to think about if your primary goal is quality improvement and practice of implementation. Translational Behavioral Medicine is another journal in the field that's been around for some time. It is the Journal of the Society for Behavioral Medicine. It's published by Oxford Publishing. And its focus is on behavioral medicine, which is largely, again, mental health. But they focus on the sort of psychological aspects and treat implementation as behavior change, which I've been talking about, largely at the individual level, less at the organizational level, which is critical to implementation research and practice, as we've talked about. So when work is being done predominantly at the individual level and predominantly, for example, uses the theoretical domains framework, then translational behavioral medicine might be a good venue for thinking about publication. Other journals have begun to publish implementation research regularly. Medical Care, which is published in the US, and the Journal of General Internal Medicine, also in the US. I believe that some of the European journals are beginning also to publish implementation research. And some of the journals that are best known for clinical research, like the Journal of the American Medical Association, New England Journal of Medicine, Lancet, and BMJ, British Medical Journal, are all beginning to publish implementation research and actually have published key pieces of the foundations for implementation research, as well as important and large-scale implementation studies. So, I would say you can find implementation research across a wide range of journals at this point. And I think a lot of whether or not a journal will accept the work that you're doing has to do with its breadth, its significance in the field, its size. The clinical journals like JAMA and New England Journal of Medicine, Lancet, BMJ, typically only take implementation research when it's large scale and trial, so that there's randomization and other features of design and evaluation that they consider to be important. Whereas implementation science communications, implementation research and practice, translational behavioral medicine will take smaller studies and ones that may be more informative to the field of implementation research. So I hope that that's some helpful information, and I'm happy to answer any questions about the publication side.
Thank you very much for the sharing about publication. I think all of us are very excited because this is a newly emerging field in Asia Pacific, and we are trying to get to know how to publish in various venues. And actually, implementation science is one of the major themes of Hong Kong's health and medical research fund now. So I think you will see increasing numbers of work being done here in Hong Kong as well as in China. So is there any questions about publications from the audience? So if not, thank you very much for sharing her experience with us about how to design implementation interventions and provide us with a very clear framework and process on doing and initiating an implementation research projects, and also share with us some tips on publishing our forthcoming work in international renowned journals, including implementation science communication, which will surely be interested in looking at and trying to learn from reading relevant articles as well. So thank you very much for attending for this seminar. Have a good evening, and thank you again, Professor Sales. Thank you.
Thank you, and I'd just like to wish everybody a very happy New Year next week as you have holidays. I hope that you actually can spend time with family this year. I know the last 2 years have been very complicated, so best wishes for the new year.
Thank you very much.
To stay healthy and
great.
So
thank you.
Thank you, Professor Encias and Professor Vincent Chong. And I think we learned a lot on implementation research and implementation intervention. So it is the evaluation time. We love to have your feedback to our events. So please go to the evaluation form here with the QR code, or in the chat box. I have provided the link. And our school is having another webinar on implementation science next month, and we're going to update the news on our social media platform, as you can see on the slides here, on our webpage and our Facebook and LinkedIn. So you may have a look there, and we'll get the latest news to you. So thank you, and enjoy the night, and enjoy your day. And
thank you.
Thank you.
Bye-bye.
Bye-bye.
Bye-bye.